Hello and welcome. This is the PEMeast education meeting recording for March 2022 with a theme of shock. This is the first of two talks called Turning Off the Tap. My name is Dr. Daniel Morell. I'm a paediatric emergency medicine doctor who has a background in emergency medicine and also a paediatric critical care transport fellow. I'm also the PEMeast secretary. So this first talk was discussing the management of the exsanguinating child using two case discussions that I've come across. Managing major hemorrhage in children is rare and can be very challenging, and I often found paediatric doctors have rarely come across this. Massive hemorrhage is associated with a mortality rate of up to 60%, so this will discuss the approach and we'll go over the main learning points from the talk, and we'll do a deep dive into the evidence behind major hemorrhage management. So you may have heard the phrase damage control resuscitation. Damage control resuscitation was originally coined by the US Navy. Essentially, it's a systematic approach to the management of trauma patients with severe injuries. And the idea is that you shouldn't try and fix everything in one go, as definitive operations are often long and associated with high complications rate, as there's an ongoing metabolic stress, inflammatory effect of trauma, tissue healing and ischemic time. So the aim is trying to control hemorrhage, maintain the circulating volume and end organ perfusion, prevent coagulopathy and stop any further damage to tissues by fully resuscitating and delaying definitive operations for later on. So there's three elements to this: hemorrhage control, so where's the bleeding coming from, and damage control surgery or interventional radiology to control the bleeding. And if you're in a centre which does not have the facilities to do this, then you need to think about how you're going to get your patient to those hospitals. Hemostatic resuscitation, so replacing blood loss, maintaining end organ perfusion, and we'll also discuss this term called permissive hypotension. And also you need to seek and treat any coagulopathy with blood products. So the first learning point I want you to take home is that when you approach these patients, you need to think, I need to turn off the tap, i.e. stop the bleeding. Now, I've had the privilege of working with many doctors from the armed forces who've worked in many combat zones, including Camp Bastion in Afghanistan and Basra in Iraq, and we always hammered this home: you need to turn off the tap. And this has made its way into civilian medicine, so the latest edition of the Advanced Trauma Life Support course, the managing catastrophic hemorrhage is the first thing you need to prioritise before you move on to the airway and breathing and the other elements. So what are the sources of bleeding? So the most obvious source would be external hemorrhage from wounds, but these sometimes can be hidden, so especially in the context of penetrating trauma or stabbings. So wounds, often areas that are missed are the axilla, groin and back, so pay special attention to these areas. Long bone injuries or fractures can be associated with significant blood loss, especially for femur, so looking for any swelling or deformity of long bones is important. And then other areas you need to consider would be facial trauma or ENT bleeding, so from epistaxis or post-tonsillectomy bleeding, or bleeding from genital areas. And then you've got your chest, abdomen, pelvic and cranial cavities which you can bleed into. Now, the reason why the top half of highlighted yellow is that these injuries are often compressible within the resuscitation room during your initial resuscitation. However, chest, abdomen, pelvic and cranial bleeding, it's a lot harder to compress, and therefore you need to think about these patients will often need surgery or interventional radiology. There have been many attempts to try and tamponade bleeding, such as intra-abdominal foam. You may have heard in the pre-hospital setting resuscitative endovascular ballooning inclusion of the aorta or REBOA, which is from femoral access, ballooning the aorta to occlude it at various levels. However, this is not readily available in the UK, so these patients will need to go for surgery. Now, it can be very challenging to identify sources of bleeding, so you can think about adjuncts to help you with that. So the first thing to remember is don't forget your foreign bodies. Button batteries are notorious for causing mucosal burning into vessels, which can cause major hemorrhage, and plain film imaging can often be rapid, and these things are often radiopaque and can help with diagnosis. Other things that can help you is that if you've got an NG tube in situ, that aspirating it and getting blood may indicate that a GI bleed. And the other thing we'll talk about is focused point of care ultrasound, or POCUS, and specifically focused assessment sonography in trauma, or fast scanning. Now, fast scanning is essentially looking for evidence of free fluid that's collected in various abdominal, in areas of the abdomen, such as in the top image, in the right upper quadrant between the liver and the kidney, in Morrison's pouch, or below that in the left upper quadrant between the spleen at the top and the kidney, or in the pelvis. So the top view, the pelvic view, is a sagittal view of the pelvis, and below that is a transverse view with the bladder at the top and the free fluid appearing black in between. Now, these the benefits of sonography is that is a rapid way of identifying blood loss in the abdomen and pelvis. You can extend these views to get the chest and pericardium as well. However, you do need a significant amount of blood loss before you can get a positive scan. So in the context of what you look, the black stuff would be deemed as free fluid, and in the context of trauma, it's blood. That's blood until proven otherwise. And in adults, you need up to or over 300 mils of blood loss before you would get a positive scan. So therefore, a negative scan does not rule out injury, and it's therefore a rule-in tool rather than a rule-out tool. It's also quite user-dependent, and often sometimes the views in a chaotic resuscitation environment can be difficult to obtain. And also, paediatric trauma is different to adult trauma. So the most common injury in children is transection of the pancreas, and other retroperitoneal organ injury, which is difficult to see on ultrasound. So therefore, this has led to the Royal College of Radiologists stating that ultrasonography is not recommended in assessing paediatric trauma patients. The caveat to that is that I personally think it can be useful in certain circumstances, especially in aiding clinical decision making. So if you've got, for example, a child that is hypertensive and bleeding, and your surgical colleagues may be reluctant to take to theatre, a positive fast scan may help with that decision making. So if it's not going to delay definitive surgery or definitive imaging, then there may be a role for it in bleeding, in the child that's bleeding. So once you've identified where the bleeding is coming from, especially in the compressible hemorrhage, what strategies are there to help you control the bleeding? Well, the obvious one would be direct pressure over the wound, which is probably the most immediate thing you can do. Other things you can do is that if it's a bleeding from a limb, you can attempt to occlude or put pressure on the vessel above that. So, i.e., like in a lower limb wound, so putting pressure in the femoral triangle to occlude the femoral artery, or in the axilla for the upper arm to gain hemostatic control. Further on for that, you can use the tourniquets. Trauma tourniquets are designed to be self-administered, and what you do is you apply the tourniquet and use the stick to twist it to tighten the tourniquet. Obviously, you need to be able to apply the tourniquet above the wound that you're trying to control the bleeding for. And the other important thing is that you need to note the time. So if tourniquets are left on for more than 4 hours, they're associated with increasing irreversible ischemia of the distal limb. You can consider wound packing or wound dressings to compress bleeding. And there's a special type of dressing called celiac dressing, which is pictured, which also comes in powder form, which is made out of shellfish. And what it does, it causes blood to coagulate on contact, so it can be quite useful especially with wounds that are bleeding profusely. The caveat to that is that you can't really use it to pack blind cavities, as it's not absorbable and it poses an infection risk. But again, it can be helpful with bleeding wound management. With cases of especially scalp wounds, rapid closure may be necessary. I often find staples being quite helpful with this. And if you can see vessels that are bleeding, direct clamping and tying off these vessels again are helpful to gain hemostasis. And then in the context of facial trauma or bleeding, bleeding from the mouth and nose, or face, you can, if the patient's intubated, you can consider throat packs. You've got nasal packing, balloon packing, that's pictured. And then in maxillary facial injuries, you can consider using bite blocks, which are pictured, which essentially what we do is align the facial bones into position to cause tamponade bleeding. To use these, the patient would need to be intubated, and then you can use the C-spine collars to fix the mandible in position to cause the facial bones to go back into alignment. And then following from that, the use of long bone splints to reduce and straighten fractures via traction is very effective in tamponade long bone bleeding. So pictured below is something called a Kendrick splint, which is a temporary splint to apply traction, and you can use it in the upper arm. Again, you can only use this for a limited amount of time, as it will cause pressure sores if left on for long periods of time. So when practically possible, you need to switch to skin traction. What other interventions are there? So tranexamic acid. Tranexamic acid is a ED favourite, so it's an antifibrinolytic agent which stops plasmin formation and therefore fibrin breakdown. And in the context of trauma and major surgery, it's been shown in the CRASH-2 trial to reduce mortality in adult trauma. So the CRASH-2 trial is a famous trial where they gave tranexamic acid to trauma patients, so 1 gram over 10 minutes followed by a 1 gram over 8-hour infusion within 3 hours of the first bolus. It's a famous trial because it was stopped early because there was such an overwhelming evidence for an overwhelming benefit for giving tranexamic acid that it was deemed unethical to carry on the trial. So the practice of giving tranexamic acid to trauma patients was started. However, they didn't look at children, and there's a lack of evidence of tranexamic acid, what dose and when to give it in order to help manage bleeding. There is evidence in other areas of paediatric medicine or paediatrics, such as paediatric cardiac surgery, where tranexamic acid has been shown to reduce blood loss during surgery, and in scoliosis surgery, there's also the use of tranexamic acid has been shown to reduce the need for transfusion post-operatively. So this has led to a consensus statement from the Royal College of Paediatrics and Child Health that in the trauma patient, children should be given tranexamic acid at a dose of 15 milligrams per kilo as a bolus, followed by a 2 milligram per kilo infusion over 8 hours. However, in non-trauma patients, there's no evidence of tranexamic acid benefiting patients, those in disseminated intravascular coagulopathy or DIC. And in adults, tranexamic acid in upper GI bleeding is not shown to be of benefit in reducing mortality or morbidity. So in the context of these conditions, it's not recommended to give it. So other things, giving vitamin K, especially in patients who are on warfarin or have liver disease. And then those patients who are anticoagulated, there's your anticoagulating reversal agents, such as Beriplex and Octaplex for warfarin, Praxbind for dabigatran, and then you've got your anti-10A reversal agents to reverse apixaban and rivaroxaban. Now, these drugs would need to, if you were to use of these drugs, need to be discussed with a haematologist. And the reason behind it is that these drugs, especially the newer one, anticoagulants, have relatively short half-lives, and depending on their last dose of anticoagulant and their INR, or their what degree of coagulation they have in their blood, whether they would benefit from these drugs would need to be discussed with a haematologist. Often the clearance of these drugs are dependent on renal function, and the other caveat is that these drugs are often quite expensive. Proton pump inhibitors, so the theory behind that is in upper GI bleeds that reducing the pH of the stomach reduces the clot breakdown rate and stabilises the clot. Again, there's limited evidence, and in adults it's not recommended to use proton pump inhibitors in patients with non-varicella upper GI bleeding prior to endoscopy, as there's no reduction in mortality, rebleeding rates or need for surgery. But it is offered post-endoscopy if there's evidence of recent hemorrhage. In children, GI specialists recommend giving PPIs if it's not going to delay endoscopy. But again, there's limited evidence. In varicella bleeding, you can use octreotide or vasopressin, which reduces portal hypertension or induces portal hypotension to reduce bleeding from esophageal varices. And if your patient's over 40 kilos, you can potentially use something called a Stagsden Blackmore tube, which is pictured on the right. These are specialised NG tubes, which have two balloons. So they have a gastric balloon and an esophageal balloon. What you do is you insert the NG tube, you inflate the gastric portion, pull it up to tension on the upper part of it, and then you inflate the esophageal balloon to tamponade the varices. Now, as you can see, these NG tubes are very big, and your patient will need to be intubated before you can insert one of these. But again, that's something you consider using in the context of upper GI bleed. So now you've got your bleeding under control, what do you do next? Well, you need to replace, your patient will still need volume, as inotrotes won't help because you've got an empty system, and as the second part of your damage control resuscitation, you need to, we'll talk about hemostatic resuscitation. So for this, we need to talk about what happens in severe blood loss. So in severe blood loss, you'll get an increase in your lactic acid in your blood, which will make your blood more acidotic. This in turn will decrease your cardiac output, which will cause your body to become hypothermic, which will increase any will decrease your coagulation and create a coagulopathy, which then will cause more bleeding, which will then cause more hyperperfusion, will cause more lactic acid in your blood, and you will get into this vicious cycle, which will result in death. So this is called the trauma triad of death. Following on that, so in trauma and surgery, you get tissue injury, so you get release of tissue factor release and coagulation. But in severe blood loss, that you get consumption of this, so you get a progressive coagulopathy, which will cause more bleeding, systemic hyperperfusion, which will cause thrombomodulation expression, so more protein C activation, thrombin generation and fibrinolysis, which then will make worse than any acidosis, cause more bleeding, more hyperperfusion. So, following from that, my second learning point is when you thinking about what can we give to resuscitate our patient, salty water should only be used to cook pasta, i.e. you need to use limited crystalloids. Now, if you think about what we're trying to prevent when we're managing these patients, is you need to replace blood to reduce your blood acidity. It needs to be warm, and you need to have some. You need to give some clotting factors or clotting to help with coagulation. Now, if you ever look at what is in crystalloids, so take normal saline for example. So normal saline has a pH of 5.5. It has no clotting factors. It has no oxygen carrying capacity, and is quite acidic. And if it's not warmed, will cause hypothermia, and may cause clot dislodgement by increasing the pressure in the intravascular space. So if you're trying to prevent the triad of death, giving something that has no clotting factors will cause a dilution or anemia because it's got no oxygen carrying capacity, is acidic, and is cold, is not going to help your triad of death. So what can you do instead? You can activate the major hemorrhage protocol. So what is a major hemorrhage protocol? It's a rapid way of retaining blood products, and which is available in most UK hospitals. Essentially what it is a 2222 call, and on the slide to the right is the East of England major hemorrhage protocol in children standard, essentially, as per the local haematology, East of England haematologists. So what we'll do is we'll talk through this protocol. So following assessment of your patient, you need to get IV access, so i.e. large bore cannulas, and you need to send some blood tests for cross-match FBC, clotting factors, biochemistry, so including liver function, calcium phosphate, and get a blood gas to measure lactate. Give you a tranexamic acid in trauma, and it says resuscitate with fluid if you haven't crystalloid if you have nothing to hand. But if you get once you activate this, what happens is that the hospital blood bank, haematologist, and relevant teams will be alerted to your patient. So what happens? So you get a primary pack or pack 1, which contains in the East of England it will contain packed red cells and fresh frozen plasma. So in the East of England, you'll get up to 30 milligrams per kilo of packed red cells, or up to 5 units, and you'll get 15 to 30 mils per kilo of fresh frozen plasma, up to 4 units. In pack 2, should you need it, you will get blood, packed red cells, fresh frozen plasma, but you additionally will get platelets and cryoprecipitate. Cryoprecipitate is high in fibrinogen and it contains factor 8, 13 and von Willebrand factor. And often when your patient is bleeding for a long time, your fibrinogen is depleted due to the dilution, and therefore giving cryoprecipitate will help your clotting. So this may change in later. There's a trial ongoing called the Swiss trial, which is looking at giving whole blood products instead of separate products in the pre-hospital environment, which is an ongoing trial. So how do you give it? So the idea is that you need to give it in a balanced ratio. So there's evidence to suggest that in systematic reviews that giving balanced blood products, including platelets, patients have better outcomes, which will all make sense because you're trying to, blood has different constituents, so you need your plasma, you need your red blood cells for your oxygen carrying capacity, and you need your clotting factors. So you may have heard this ratio of 1 to 1 to 1. So 1 to 1 to 1 basically means that you give equal amounts of red blood cells to platelets to fresh frozen plasma. And where it comes from is essentially from the military, and it's the way they gave blood products in combat situations. Richard Dutton, who's an anaesthetist in the United States, did something called the PROPER trial, and what they were looking at in this trial is actually giving blood products to trauma patients in the civilian setting at a ratio of 1 to 1 to 1 versus 2 packed red cells, or 2 to 1 fresh frozen plasma and 1 platelets. Now this was a bit of a controversial trial at the time, as it was underpowered, and essentially it showed no difference between the two groups. However, there was in a secondary analysis, there was a slight decrease in death from patients who received the ratio of 1 to 1 to 1 at 24 hours. So the headlines for that is essentially you need to give blood products in a balanced way, but it doesn't make too much of a difference if you give it 2 to 1 rather than 1 to 1. And if you look at the protocol here, it says in trauma patients you should aim for a ratio of red blood cells to FFP of 1 to 1, and other causes of hemorrhage as 2 to 1 packed red cells to fresh frozen plasma. So moving on from that, how much do you need to give, and what you're trying to targeting? So this idea of limiting fluid resuscitation in trauma dates back from World War One. So Walter Cannon in 1918 thought or witnessed that giving lots of fluid to patients may worsening their bleeding in trauma due to dislodgement, and actually giving lots of fluid in trauma in bleeding patients might not be the best idea. And then nothing really happened with that for a while until Maddox and Bickel in 1994 did a trial looking at 600 patients with penetrating torso injuries in the United States. And what they did is that they delayed resuscitation until these patients got to theatre, so they didn't give any fluid at all, versus aggressive fluid management. And the difference between the fluid the patients received was about 3 litres. And actually there was a mortality benefit in delaying resuscitation before definitive surgery. So the patients who didn't receive any fluid before theatre actually did better than those who did. And what's the reasoning behind it? Well, so if you overfill the intravascular space, or not fill it, or reduce its filling, what you achieve is that you might get better clot formation and stabilisation because you're reducing the pressure inside the vessels. You're enhancing vasoconstriction because you need to maintain your cardiac output. And actually giving lots of fluids, you're avoiding the iatrogenic effects that we were talking about earlier, or you'll avoid over-resuscitating the patient, causing more bleeding. However, it's a bit of a balance between inflicting ischemic stress because you're underfilling a already sick patient and causing worsening inflammation, acidosis, and coagulopathy. Now, in children often are already adequately vasoconstricted because their vessels are usually not diseased. So, and often children will basically. I'm often quite amazed how well children can vasoconstrict in order to maintain their cardiac output, which is quite fixed, and therefore, actually, the strategy of using permissive hypotension may not is likely not really have a place in managing pediatric major hemorrhage. So what sort of targets are you looking for when you're trying to resuscitate these patients? So in adults, you would probably try and aim for a mean arterial pressure of about 65 or a systolic blood pressure of over 90 with blood products. Unfortunately, in children, there's not really a consensus for what best mean arterial pressure is, as it differs quite significantly with age. And hopefully, with things like the pressure trial, that there might be a bit more clarity on this. But essentially, what I would try and aim is for a normal normal systolic blood pressure for that aged child, or evidence that you're perfusing their end organs, i.e., if they're not already intubated, whether they are more awake, or if they're producing in the urine, for example, or you've got good peripheral pulses. But ultimately, these patients need to get to their definitive management, so that's what needs to be prioritised. Other considerations, so if you go down, is that giving lots of blood products have citrate in it, and that's in order to chelate them and stop them coagulating when in storage. However, when you give lots of these products, it will cause hypocalcemia, which will cause cardiac depression, which will lower your cardiac output, which again will cause ischemia and acidosis. So you need to keep an eye on your calcium, and sometimes you might need to bolus IV calcium to supplement the calcium in the body. And then you need to give your fluids warm. So often you should have available to you in all hospitals fluid warmers. Belmont rapid infusers or other rapid infusers will give products warmed. So a Belmont can give up to 500 mils per minute of fluid warmed to 37 degrees. So targets that you should aim for, so you need to aim for a temperature of over 35, you need to aim for a pH of over 7.2, base excess of -6, lactate under 4, ionised calcium of 1.1, platelets over 50, fibrinogen of over 1, and an INR of under 1.5. But blood products, or giving blood products, is not perfect. So as you can see, this is a blood cast taken from a pack of packed red cells. So it's still a little bit acidotic. You are giving about 150 mils of anticoagulant per 500 mils of packed red cells, and it only has 29% hematocrit, 88 platelets, and 60% coagulation activity. So it's not perfect, and actually that should home on the first point of that. You need to turn off the tap and you need to stop the bleeding. So what actually happens in the wild west of hospitals, especially in non-tertiary hospitals, or what considerations do you need to think about when managing these patients? Now, these are obviously very stressful resuscitations, and you need lots of help. It can be very chaotic, and you need to think about your human factors. So you need to identify a team leader, which will often be the emergency medicine doctor. But I would also advocate having a separate blood team to check, load and administer the blood products. Also someone to liaise with the blood bank. Now the blood banks are often can often be not obstructive, but can be reluctant to release blood products because of our own governance. They want to prevent waste, because once blood's issued, it can't be and open, it can't be reused, and using lots of blood products can be expensive. So allocating a person or team to liaise with a blood bank, say what we need, what blood products are needed, and how quickly type specific blood is available is helpful. And what often happen is that instead of getting pack one like we talked about, what you'll get is what's sometimes called flying squad blood, where you'll get 2 units of packed red cells only before you get FFP. And the reason behind that is that actually fresh frozen plasma needs about 20 minutes to thaw, so unfreeze, before it becomes available. So you just need to be aware of that when you're giving your blood products, is that you might not have fresh frozen plasma immediately available. And often in non-tertiary centre hospitals, there's a limited availability of platelets. And the reason behind that is that platelets have got about shelf life of 7 days, and it's not given very often. And what normally happens is that when platelet transfusions are given, it's usually in a planned environment, and usually for haematology patients. And often they'll have usually maybe 1 or 2 units available, and then they'll have to courier the rest. So you need to bear that in mind, that you might have limited platelets available. And one other things you need to consider is that your team may be in an unfamiliar environment and may be unfamiliar with the equipment. Rapid infusions aren't used very often. So I would encourage all of you to have a look at in your local resuscitation area in your department or in theatres, and have a look at how the rapid transfusions works, or how it's put together and primed. And then often these patients will need to be transferred. So if they need ongoing blood transfusions on transfer, you need to think about the governance behind that. So essentially, any patient who needs blood transfusion during transport should, before leaving, need to have the blood prescribed, collected and signed out with the forms attached, and the products need to be transferred en route, or if not, they'll need to be in a appropriate transport blood box, which would be provided by the laboratory. Packed red cells and platelets need to be transported separately, and you need to ensure that there's the correct ID bracelet on the patient, that the risks of transfusions are discussed, and the referring hospital needs to inform the receiving hospital that the patient's travelling with ongoing blood transfusion, and which area of the receiving hospital that the blood transfusion where the patient will be going to. During transfer, you need to ensure that all the paperwork is correct, and that any blood products given during transfer is documented, and the reason behind any leftover blood products, and any unused blood products that are in the box needs to remain sealed, and that the cold chain audit trail needs to be maintained. And then once units have been opened, they need to be used within 4 hours. And then on arrival, products need to be signed over to the receiving hospital staff with the documentation which stays with the patient, and then the products stay with the patient, and the traceable documentation is then sent over to the transfusion lab in the receiving hospital. So in summary, when managing these patients, when managing the paediatric major hemorrhage patient, you need to remember, you need to turn off the tap, i.e. you need to stop the bleeding, and remember your damage control resuscitation. When giving products, or when resuscitating, salty water should only be used for cooking pasta, so you need to activate your major hemorrhage protocol early and get early use of blood products. And major hemorrhage is not a team sport. You need lots of people, you need lots of help, but remember your human factors. So you need to allocate team leaders, you need to allocate a blood team to manage the governance and administration of blood and liaise with the blood bank. These are the references. So I hope you enjoyed that talk. Please send any questions on the PEMeast Trello board.